Good morning. So I'll be talking about fusions in foot and ankle surgery. So basically, we always start with the clinical problem, what the question is, and the goal in foot and ankle is frequently to achieve fusion of bone in an area where nature or God intended there to be a motion segment. Which there's a lot of different various factors that play into this. They can be, patient-specific things that are working in against you, such as diabetes, smoking, age, medications they might be on, including steroids. And then there's also some certain specific factors, joint preparation, the type of fixation you like to use, and then I think what this talk is kind of about some of the new technologies or medications that we use to help achieve our goal. So just depending on the study that you read, the non-fusion rate is about up to 10% for procedures throughout the foot and ankle. And obviously the goal is to avoid what we see on the right of the screen, the left, and to achieve what's on the right, which is good osseous bridging of the fusion site. And the problem with this is that the non-fusions are headaches for patients, they're headaches for the physicians taking care of them, and they cause problems for the healthcare system down the line. At the basics, these are some tidbits from the basics of bone healing biology, which we'll frequently see on the OITE exam, but we all know that there are three aspects of bone healing. You have osteoinductive, which comes from the proteins in the milieu, in the area biologically, osteogenic, which are the cells that produce, so your osteoblasts and your osteocytes, and then your osteoconductive, or your scaffolding, which makes up the matrix that allows the bones to form. So within our armamentarium at this time, we have a litany of options. These include bone graft compositions from demineralized bone matrix, allograft, or autograft, which is currently still considered the gold standard, specifically from the iliac crest. Autograft in general, so the pros of it are it's autologous. You have no chance of rejection, no chance for disease transmission. It's osteoinductive, it's osteoconductive, and depending on where you get it from, the percentage of stem cells, it can also be osteogenic. All three of the properties that you need to allow for bone healing. The cons, there's donor site morbidity. This is not insignificant. It's reported to be up to 20% in the literature for minor and up to 4% for major complications. That's specific for iliac crest, but it's still relevant. There's also the difficult balance between cancellous and cortical composition, and also having enough of what you need. Local bone graft does offer the advantages of being able to do it from one surgical site frequently and using regional anesthesia. The issue with that is, for example, in the foot and ankle, you're going to have lower stem cell counts and a lower total volume of the graft that you'd need. Iliac crest, on the other hand, has the advantage of having a very high stem cell count. Recent investigations show that is the most rich place to find the pluripotent stem cells that allow for bone formation. There's a decent amount of volume for use in the extremities. The disadvantages are a second operative site and significant postoperative pain reported in, again, up to 20% of patients. So getting more to our options. Allograft is probably the one that we're all the most familiar with. It is osteoconductive, but has no osteoinductive or osteogenic properties. This is a fresh frozen femoral head, probably more frequently used for structures that are larger or when you need interpositional graft. You have the advantages of ample supply. There's no donor site complication. And then obviously, if you're switching from allograft to autograft, it can frequently take a procedure that you would maybe have to admit a patient for to being an outpatient procedure. The disadvantages are there's a broad array of sterilization and storaging processes which can make the grafts of different quality. And there's also a low but significant risk for transmission of diseases anytime you're using any sort of allograft product. The next is demineralized bone matrix. It has osteoinductive but no osteoconductive properties. It's essentially defined as an allograft process to remove the minerals but preserve the proteins of the bone matrix, including collagen. Again, the advantage is no donor site morbidity. However, and I think this is fairly significant to understand, the processing between and even among the producers is variable, such that in certain studies it'll show that the lot number between two of the same exact product can have wildly different chemical compositions as well as properties for what the result is on the application. Here's some literature from 1996 core. 55 patients undergoing two types of fusion, subtalar and triple arthrodesis. It was compared to iliac crest grafting. There was no statistical significant difference in the rate of fusion. However, there was a statistically significant difference in the complications. And also, there was less blood loss with the demineralized bone grafting. And there were 2 infections after the iliac crest graft from the donor site. Then there's also your bone graft substitutes, which I think we're more familiar with from the trauma literature. These can include hydroxyapatite, calcium phosphate, calcium sulfate. To be honest, in most of the literature reports for foot and ankle, these are often used in conjunction with one of the other products that we'll be talking about more later down the line. But it's safe. It mimics the porous structure, so it's osteoconductive of bone, and it can rapidly decrease or significantly decrease your operative time. However, there's lack of evidence specifically evaluating the application in foot and ankle surgery, again, because it's more commonly used in the trauma literature, and it's actually thought of less of a bridging application and more of a filling a void defect, which we can understand why that would be more common, for example, in a tibial plateau fracture and less common in achieving subtalar fusion. There's some of these other more newer products, more of the biologic classification. Platelet-derived growth factor is one such product. It has osteoinductive properties. It is actually currently approved by the FDA for use in foot and ankle surgery. The thought is that it promotes vascularity, angiogenic, mitogenic, and chemotactic properties of the cells to the site. So the goal there is to increase the amount of native osteogenic potential in the area. It has been used in combination with bone graft substitutes and has had positive results. However, I do think that the results of this product relative to some of the more advanced, such as BMP or stem cells, is probably not quite as advantageous, and as we'll see later, it's almost as expensive. So I think that some of the applications for this are waning in light of some of the newer technologies. Regardless, you can see that it did have a statistically significant advantage in this investigation over autograft. BMP, we all know about it. It's probably more commonly associated with usage in spinal fusion. However, there are off-label uses for it in foot and ankle surgery. It, of course, is osteoinductive. It's a protein, part of the transforming growth factor superfamily. It's a modulator of osteoprogenitor mesenchymal stem cells. It increases your pluripotent differentiation into osteocytes and osteoblasts. There's a theoretic cancer risk, and it has also never been validated in foot and ankle surgery. However, this is a rather compelling investigation from FAI in 2009, where they took 69 patients who were all actually prior non-unions that had needed revision surgery, and 96% of them went on to achieve fusion after the revision procedure with DBM at 11 weeks. So there was no significant difference between time to union and fusion to site in these, and they tried it for fusions of the ankle, the subtalar joint, talonavicular joint, and the calcaneocuboid joint. I can also say that the statistical analysis in this paper was fairly rigorous and appropriate. Platelet-rich plasma is another potential augment used to achieve fusion. It's thought to have osteoinductive properties similar to the biologic effects of BMP, but again, in my mind, just because of the different preparations of PRP, as well as the different ways to do the release, and the lack of consistency between producers or even in between the preparations and the individual who it's harvested from, I don't think it's probably quite as reliable as something like BMP, where you know what you're getting when you apply it to the fusion site. But there are some studies showing that it has some success. This study, interestingly though, fusion wasn't the endpoint. It was more of the foot and ankle score a year post-operatively, and it was shown to be with allograft no better than the autograft, and it was significantly better than allograft alone, which isn't very surprising. And then, of course, there's probably some of the newest technology, which is the allogenic stem cell preparations. I think the one that we're most familiar with at Duke is Trinity Elite. It's thought to have osteogenic properties because you're, again, depositing cells locally into the site. It's usually mixed with some other form of osteoconductive graft. And there are, again, pretty impressive results with this as well, 91% greater fusion rates without any evidence of graft rejection, which I think is probably a fairly significant finding considering that you're implanting allogenic cells into a fusion site. So you wouldn't want an autoimmune reaction there. Always important when we're thinking about things like this and the newer technologies now is to consider the costs. As you can see, a fresh femoral head graft is not very cheap. It can be $2,000 to $3,000, whereas cancellous chips, if you don't need that structure, is a little bit cheaper to fill the void. But both those are less expensive probably than some of your calcium sulfate or calcium phosphate void space filling options. Demineralized bone matrix is a little bit more expensive than the cancellous chips. And then when you get down to the biologics, you see the price really jump up. EMPs can be $3,000 to $5,000. PRP is cheaper, but again, I don't think the results are as reliable, nor are the preparations. And then, of course, there are the stem cells, which again are fairly expensive. So ultimately, how do you choose which of these options to use? And I think it probably depends on what you're trying to achieve. If you need to have a structural benefit, then you're probably going to use something more like an allograft that can provide you with that structure, and then you might augment with some stem cells or some BMP. But I think there's also other factors to consider, which would include the cost, as well as what the surgeon preference and experience with certain products are as well. So I'd like to thank the foot and ankle team and open it up for discussion. These are my sources.
So that's a great review of all different ways you can get things to do. So I know you said you're going to leave it up to more erudite minds to decide what to select, but one day you're going to be the erudite mind. So when you're out on your own, how are you going to pick? I'm going to ask you two questions. First, how are you going to pick, and then I'm going to ask you the second question.
I guess it would be based on a combination of costs and what the literature shows. I think right now, I would hope that BNP will come down in cost. And I like the idea of using that to achieve fusion, particularly in some place that you're not worried about an overzealous reaction, like in the neck. And I also believe that relative to stem cells, I like the idea of it not having the potential for any sort of rejection. I think anytime you implant cells that are not of your own substance, that you open yourself up to the potential to have that. So I think DNP offers the advantage, and I think it'll also probably go down in price because the processing costs will go down, whereas anytime you're needing a donor, I think the cost for that product will be increased.
Well, what do you think about it when you deal with things like, it sounds like everything's more than 90% effective, right?
Except for the platelet-derived growth factor.
Yeah, platelet-derived growth factor. So you have a bunch of things that are more than 90% effective. One could argue that even though there's statistical differences between the tests, because they're not all done the same way, they're probably all error about the same, would be my guess, if you really want to be very rigorous about it. So when you have a situation like that, which we have lots of in orthopedics, a good way to select the things is you look first what's best for the patient, what they would want. So an example would be iliac crest versus not. You might say, well, maybe a little more blood loss or complication of iliac crest, but it works pretty well. But if a patient doesn't want an iliac crest biopsy, the extra surgery for the iliac crest, you can't even do it. Second thing is what's better for you. So things you're comfortable with. If there's a technique or a technology you're not comfortable with, it's not good to do it because you might not be able to do it so well. And the third thing is what's good for society. You take it in that order. Okay, what's for the patient, what's good for the patient, what you're comfortable doing, and then what's good for society. And then you take it into the cost considerations. So you might want to just take the one that's least expensive. So the second question is, what if it's your foot? I'll answer for me second. What if it's your foot and your ankle? What would you pick?
Probably a combination of
Sorry?
A combination of some sort of structural graft and BNP right now.
And if you ask the foot and ankle people what they would think if it was their foot,
Total ankle.
I'm going to answer last what I would do.
It's a real dilemma, and the dilemma is the cost versus the risk of failure. So we would gladly use, I think, BNP first, and then we're getting to the platelet-derived growth factor now, which has come on the market, and that's going to be a big deal. But the cost is just incredible. I think 20 years from now, we're going to have a mixture of probably newer devices that are considerably less expensive, and that we'll use them routinely, and we'll look back and say, I shouldn't believe they weren't using those because I don't know if you looked up what's the cost of refusion of a ankle arthrodesis.
Greater than 15,000.
Yeah, so 20, 30,000. So now you're weighing, okay, well that's versus that, and so we can get about 90% of our fusions healed without this stuff, but using it. The other thing that is important is to stop people from using the like nicotine ingredients that retard fusion. So I won't do a smoker. I have stopped more people from smoking to get their surgery. Not only do I have them do it, but I won't schedule them until I get a negative nicotine test. So a lady came in, we did a subtalar fusion on her. I thought we did a nice job, and she got a non-union, and we took her back to surgery. And after surgery, I talked to the husband, and I said, she doesn't smoke, does she? And he says, no, but she goes through a carton of nicotine gum every week. And so I've had that situation with chewers and now nicotine gum. So Dr. Donnelly says that, well, I'm in North Carolina, and you got to do those smokers. Well, I don't have to do those smokers.
I'm going to tell you, and I'm going to get an outline here, I like iliac crest bone graft. So if I have to come in to operate on me, I want my iliac crest bone graft taken first. And to show this really true, I can tell you, this is a violation, so I'm telling you about myself. But several years back, I had this smooth benign tumor in my mandible. They took out, they lost a tooth, they had the bone graft, they wanted to use allograft for it, and I didn't take my iliac crest. I made the surgeon really upset because it's going to make the operation take longer. But I've done it for myself, it healed just fine. So I always think iliac crest is your own bone, no reaction as long as you don't drop it on the floor and get infected and have cells in it. So I don't bring iliac crest.
Sure. One question. When you made a comment early on that bone marrow-derived tissue has a higher concentration of stem cells for bone grafting. We maybe have been brainwashed by the companies and by Arnie Kaplan about adipose-derived stem cells having a much higher count of useful stem cells. Can you give me a reference, and did you read anything about that?
So the reference that I was using was actually when they looked at it from different osseous sites. So it didn't have any comparison to adipose stem cell tissues. And off the top of my head, I can't say I know those numbers myself. Which I guess that would be an interesting thought process. But the citation for that is relative to other osseous locations of cancellous stem cells.
We'll see if we can get Matt help working on that.
Any questions?
I don't know if things have changed in the last 2 years or they're different here, but what I faced for many years at the end of my practice was the reluctance or unwillingness, I would say, of 2 hospitals I worked in to allow me to use OP1 or BMP7 because of the $4,500 or $5,000 cost unless the insurance of the patient or the patient themselves would pay for it. So I was forced to go through a pre-authorization process with the patient, and then if the patient's insurance wouldn't pay for it, I would have to say to them, well, I can do an iliac crest bone graft with potential complications, etc., or use this product that works well if you're willing to pay for it yourself. So I don't know if you can just routinely use it here, and you will absorb the cost, or they make you go through something.
I don't know the answer. I've used it, and they always give me trouble. They give you trouble to use it?
Yeah. So I will got a couple of thoughts from the spine world. So you got to be really careful. So lots and lots of studies in the spine on BMP, and they all look phenomenal. And then when they really got investigated, and you found out they were done by people that were making money on the product, that there were even marketing people that were modifying the papers. And so unfortunately, when you read a study in a peer-reviewed journal and it's been altered, so I don't know how you figure that out, but you just have to be careful who those studies are coming from. Success rates, when the autograft fusion rates are really low, I think you really have to ask, is there something funky going on with this study? And then the other thing, you do have to be careful with these non-FDA uses. So number one, you probably need to tell the patient. Number two, at least in the spine world, I can guarantee you right now, if you are doing a procedure and you're using something non-FDA approved, the insurance companies are generally denying the entire procedure. So, and that's probably going to be coming in the other parts of the body if you're doing off-label uses. So no, they aren't just paying for it. And if the hospital lets the surgery go through, then the hospital is going to eat the cost potentially not only of the BMP but the entire procedure.